sqadia.com is advancing towards special video series, where we are specifically covering major aspects of pharmacology. Watch out for more subject-related series very soon on sqadia.com.
We will be talking about anti-arrhythmic drugs today. So, the rhythm of the heart is normally determined by pacemaker cells in the sinoatrial node, SAN, but it can be disturbed in a variety of ways, producing anything from occasional discomfort to the symptoms of heart failure or even sudden death. Arrhythmias can occur in the apparently healthy heart, but serious ones, for example ventricular tachycardia, are usually associated with heart disease, usually myocardial infarction, and a poor prognosis. The rhythm of the heart is affected by both acetylcholine and norepinephrine, released from parasympathetic and sympathetic nerves, respectively. Supraventricular arrhythmias arise in the atrial myocardium, or atrioventricular node, also known as AVN, whereas ventricular arrhythmias originate in the ventricles. Arrhythmias may be caused by an ectopic focus, which starts firing at a higher rate than the normal pacemaker. More commonly, a re-entry mechanism is involved, where action potentials, delayed for some pathological reason, re-invade nearby muscle fibers, which, being no longer refractory, again depolarize, establishing a loop of depolarization, which we commonly call circus movement. Many anti-arrhythmic drugs have local anesthetic activity, which means they will block voltage-dependent sodium channels, or are calcium channel blockers. These actions decrease the automaticity of pacemaker cells and increase the effective refractory period of atrial, ventricular, and Purkinje fibers. Anti-arrhythmic agents can be classified into the ones that are effective in supraventricular arrhythmias, the ones that are effective in ventricular arrhythmias, and the ones that will be effective in both types. Arrhythmias associated with stress conditions in which there is an increase in adrenergic activity, let us say emotion, exercise, thyrotoxicosis, myocardial infarction, may be treated with beta blockers. An arrhythmia common after acute myocardial infarction is sinus bradycardia, which can be treated with intravenous atropine if the cardiac output is lowered. Anti-arrhythmics have also been classified based on their electrophysiological effects on Purkinje fibers. Many anti-arrhythmic drugs can induce lethal arrhythmias, especially in patients with ischemic heart disease. Except for beta blockers and perhaps amiodarone in myocardial infarction, there is no evidence that anti-arrhythmic drugs reduce mortality in any condition. Because of the limitations and dangers of anti-arrhythmic drugs, invasive procedures and devices are increasingly being used in serious arrhythmias as alternatives to drugs.